All right, so now we're going to talk about respiratory medications. This is going to be medications for upper respiratory tract and lower. So we're going to talk about, for our airway disorders, we're going to talk about beta 2s, methoxylanes, inhaled antifluorogenics, glucocorticoids, and leukotriene modifiers. For our upper respiratory system, we're going to talk about antitussives, expectorants, mucolytics, decongestants, antihistamines, and nasal glucocorticoids. All right. So for our beta 2 agonists, our select prototype is going to be albuterol. The majority of them are going to end in terol, T-E-R-O-L. So the most common thing this is going to be used for is to prevent bronchospasms. It's going to help with the smooth muscles in the bronchioles, resulting in dilation of the bronchioles. So it's going to help with bronchospasms and asthma. These can be long-term or short-term. If they're for short-term, they're going to help prevent an asthma attack or help stop an asthma attack that's already happening. For long-term, we would take those every day to prevent one from occurring. So one of the things to think about is this is a beta 2 agonist. So beta 2, we have 2 lungs. So the beta 2 receptors are going to go for the lungs, whereas a beta 1 receptor is going to go for the heart. So normally this is just going to primarily attack the lungs, and we're going to talk about beta 1 blockers when we get to cardiac. But what can happen is while we're activating the beta 2 blocker or beta 2 agonists, we can accidentally trigger the beta 1s. So this is going to cause tachycardia and angina with as a side effect. We can kind of get those shaky tremors along with some anxiety. So just be mindful of that. So even though it's going for the lungs, we can trigger that and get some tachycardia and angina, okay? For our nursing administration, if we need our beta 2 and a glucocorticoid, an inhaled glucocorticoid, what we're going to do is we're going to use the albuterol first to open up the airway. So that way when they use their inhaled glucocorticoid, the lungs are more open and the medication can get down. All right. And then, like I already talked about, a short-acting beta 2 is going to be used to treat an acute episode of asthma. With the acute episodes of asthma, this is going to stop our wheezing, stop our shortness of breath, stop our coughing fits, things like that. Whereas the majority of the rest of the medications that we talk about do not stop an active attack. All right. All right, so now we have our theophylline. So the goal of this is going to be to relax the bronchial smooth muscles. So very similar to albuterol. Very, very similar. So this was used for long-term control of asthma, and at one time was the primary drug of choice. It's not used so much as the drug of choice anymore because it has such bad side effects, and we have other medications that don't cause that problem. But some people will still be on this if nothing else has worked for them. So some things to think about. We can get some mild toxicity with this because it's going to have a very narrow therapeutic range. So this could be, and this is 5 to 15 micrograms per ml. I want to point this out because some of the other resources that you have may have something different that's similar. The ATI specifically says 5 to 15, so that's the one that we're going to go with. So it's a very narrow therapeutic range. If we have mild toxicity, we're going to have some GI distress like nausea, vomiting, diarrhea, and some restlessness, and maybe some anxiety. If the toxicity gets worse, it's going to change into dysrhythmias and seizures. So that restlessness is going to increase to restlessness and seizures, which is a concern. That could kill somebody, so we don't want to do that. A big thing with this, especially with the heart, the dysrhythmias, the seizures, and the restlessness, we do not want to stimulate the brain anymore. So no CNS stimulants. So CNS stimulants, that's nicotine, caffeine, that's a big one. So no caffeine, no smoking, and something that's in here, something that has caffeine in it that a lot of people don't think about is chocolate. So no chocolate. Other things that would have caffeine in it include our tea, our coffees, of course, energy drinks, things like that. So no caffeine. That includes chocolate. Also, like we said, no nicotine, no marijuana, nothing like that with the theophylline. Okay. So our next medication is an inhaled anti-chlorogenic. Okay, so we have the background. We have our desert back here because an anti-chlorogenic, as we know, it dries you up. Ipratropium is the drug of choice here. It's going to block the mucarsenic receptors in the bronchi, causing that bronchodilation. So we have a couple of uses for this. These uses could be relieve bronchospasms with COPD. And it could also help with allergen-induced bronchospasms, as well as exercise-induced bronchospasms. Okay. The biggest thing is that this is one of the few that are actually known to help with COPD. So it's going to be a big one for this. As far as our nursing implications, we want to rinse the mouth after inhalation to decrease dry mouth. Because what this is going to cause as our side effects, it's going to dry us out. So it's going to cause dry mouth and maybe some hoarseness in the throat. So that's going to have anti-chlorogenic effects, of course. But since we're just inhaling it, it's going to be localized. So it's going to be localized to the mouth and throat typically. If we have 2 inhaled medications, we need to wait 5 minutes between each medication. And the other thing, which there is a picture of it in your packet, there are some of these medications, they are given as capsules, and then they're put into a device that breaks the capsule up in order to be inhaled. So if you have a capsule of an inhaled anti-chlorogenic, you do not swallow it whole. You put it in the apparatus and inhale it. Okay. So, of course, our education with anything that's anti-chlorogenic, we want them to suck on hard candies and drink lots of water to help with that dry mouth. Okay. So now we're going to talk about glucocorticoids. Our glucocorticoids are We've talked about these. We talked about them in the endocrine system. We talked about them in the pain and inflammation system. So all of these side effects do not change at all. They're all the same. But one thing that we can look at is when they're inhaled glucocorticoids. Oops. So they're all going to end in SONE typically. We have, it's going to prevent inflammation and suppress airway mucus. So just like when we take it for pain, it prevents that inflammation of the joint or wherever our inflammation is. This is going to decrease the inflammation in the airway so that air can flow better. Things can open up more. Things can stay open. So this will help. That's how this is going to help the respiratory system. But remember, regardless as to why we're using them, everything pretty much stays the same. All right. Excuse me. So now we have leukotriene modifiers or leukotriene inhibitors. They're going to end in cast, which is why I got our little outcast right here. And I don't know if y'all remember this, but they used to wear bright yellow pants, and that's going to come back for us in just a second. I'm going to make that come full circle. All right. So we are going to, this is going to suppress the effects of leukotrienes, which is going to reduce our inflammation, reduce our bronchoconstriction, so help dilate those bronchioles so we can breathe better, prevent airway edema, and decrease our mucus production. This is going to be used in long-term therapy for asthma and can also help with exercise-induced bronchospasms. And it can also help with allergies. Okay. So we have some side effects that go along with this. Is we have depression and suicidal ideation, which is not, of course, not good. We need to monitor for behavioral changes. And we can also get liver injury, especially with our zofferlucast, which is where those yellow pants come in. Because remember, with liver injury, we're looking for jaundice. Okay. So depending on why we're taking this medication, we are going to take it once daily at bedtime for long-term asthma treatment, or if we're going to use it for exercise-induced, we're going to do 2 hours before exercise. The other piece is that this zofferlucast needs to be taken on an empty stomach. All right. So now we're going to move into our upper respiratory system. So we have opioids. Antitussives, which can be opioid or non-opioid. The biggest thing to remember about these medications, so they suppress the cough, so they stop us from coughing. Okay. But it doesn't stop us from coughing in our chest. It works inside of the brain, inside of the central nervous system, to suppress the cough receptors, to reduce the urge to cough in our brain. Okay? So that's one thing people always get mixed up, because it does stop us from coughing, but it targets the receptors in our brain that's going to have that. Okay? So, of course, our codeine, which is a form of opiate. We talked about this back when we talked about pain and inflammation. So things do not change. With the opioids, we can get CNS depression, So of course, respiratory rate is our priority. We can get that low pulse, low blood pressure, difficulty to arouse, our lethargy, our sleepy, things like that. GI distress, of course, we get constipation. And as always, we just increase fiber fluids, exercise when it's safe. A big thing to remember is that when it does have opioids in it, we do have risk for opioid use disorder. So just keep that in mind, especially if we have someone who's recovering from addiction, things like that. So with our non-opioid antitussives, so this is going to be like our Robitussin, dextromethorphan. We have, it's not an opioid in and of itself, but it does, it is derived from an opioid. So we're going to get mild dizziness, sedation, and nausea. So of course there are fall risk for both of these. But the major ones are going to come from our opioid our opioid antitussives. But again, we can still get a little bit of that sleepiness. And the non-opioid antitussives can be mixed with an opioid for pain as well. Okay. So our next medication is expectorants. These are our guaifenesin, also known as Mucinex, over the counter. So what it's going to do is it's going to promote a cough. So this is kind of the opposite of an antitussive. So it's going to promote a cough. It's going to help it thin the mucus secretion and help loosen it up so that when you do cough, it's very productive and you cough out the secretions. So a lot of times what we'll do, especially when you have a cold, you'll take things like dextromethorphan at nighttime to suppress your cough while you sleep, and then take expectorant guaifenesin during the day to help loosen and secrete those mucus production while you're awake. A big thing is that we need to take it with a full glass of water to aid in the thinning of the mucus. Okay. This really doesn't cause too many terrible side effects. You can get some GI upset with it. If you get the GI upset, we may just take it with food, no big deal. And of course, it can cause drowsiness or dizziness occasionally, so we just want to avoid driving, operating machinery, all that good stuff until we know how it affects us. All right. So now we have our mucolytics, our acetylcysteine. We have seen this drug before. We saw this drug way back when we talked about pain and inflammation. This is the antidote for acetaminophen overdose. Okay. So this is also going to be used to help thin and enhance the flow of secretion. So it's going to give us that hefty, thick, barking, productive cough. We use this a lot in children with cystic fibrosis. So the problem is because we're loosening up so much mucus and causing, it can almost clog it up. So we can have people aspirate on those secretions. So of course we need to keep suction available to prevent that aspiration. Or if they do aspirate, to be able to get it out of their airway. It can also induce bronchospasms, so we have to be very careful if we're using this in a patient with asthma, because it can trigger an asthma attack while we're loosening up all that mucus. We do need to warn our clients that it has a very, very nasty smell. It smells like rotten eggs. And of course, this is going to be inhaled as a mucolytic. Okay. And now we have our decongestants. So this is going to be our phenylphrin or our pseudoephedrine. This is going to work by reducing the inflammation inside of the nasal cavity, inside of those nasal membranes. So a couple of things can happen. How it reduces the inflammation is it constricts those vessels within the mucous membranes to help decrease the swelling so that you can breathe through your nose again. The problem is that it also causes vasoconstriction throughout the entire body. So we have to be very careful about people with cardiac conditions. Okay? Because it can cause dysrhythmias. Okay. It can cause CNS stimulation. So a big piece to remember is this is an over-the-counter medication, but you do have to show your ID in order to purchase it. And you can only purchase it in small quantities. The reason for this is that this is the main ingredient for methamphetamine, the street drug meth. So people will buy a bunch of this and boil it down and make meth out of it. Hence where the CNS stimulation comes from. That's why methamphetamines also give us that CNS stimulation. So with that CNS stimulation can come agitation, nervousness, tremors, and that could lead to a seizure. So we have to be very careful about that. Another key piece is that it should only be used 3 to 5 days. This could be for topical nasal sprays or pills. The reason for this is that rebound congestion. You're going to take that medication and then your body becomes so reliant on it that you cannot have an open airway without a decongestant. So we want to avoid that rebound congestion. So we want to keep it 3 to 5 days as much as we're taking it. Another piece of education for these clients is we do not want to have anything with caffeine in it, which we already talked about earlier with our theophylline. No coffee, no cola, no sodas, no teas unless it's decaffeinated, no chocolate. We also want to avoid alcohol and any other kind of stimulants, which could also be nicotine. Okay. And then last but not least, we have our antihistamines. So what these are going to do is they're going to block our H1 receptors. H1 being a histamine, hence antihistamine. These H1 receptors are going to cause itching, sneezing, rhinorrhea, which is a runny nose. So by blocking the receptor, we stop the itching, the sneezing, the rhinorrhea, the hives, things like that. We have first generation, which is our diphenhydramine, also known as Benadryl. a lot of people now will be like, oh, that makes total sense. I know what Benadryl does. So just remember that it's diphenhydramine is the word I will be using. So diphenhydramine can cause sedation, so it can make us sleepy. So of course we're a fall risk, and we do not want to drive or operate machinery. It also has anti-cholinergic effects because it's trying to dry up our nasal passages. So, of course, we're going to have our can't see, can't pee, can't spit, can't shit all over again. Okay? So those are our primary side effects. We can have toxicity, which can also be called a idiosyncratic effect. So this can cause it. An idiosyncratic effect is a side effect that is not. It's almost opposite of what we expect to happen. So when we take diphenhydramine, we expect to become sleepy. A lot of times, especially in children, they can get this idiosyncratic effect where it can actually cause excitation. So they're very hyper, and that can lead to hallucinations, a lack of coordination, and seizure. So just note that this is a possibility that it could occur, and it's called an idiosyncratic effect. Okay. Our second generations, we have loratadine, which is our Claritin, Sertrazine, which is our Zyrtec, and fexofenadine, which is our Allegra. Again, they do the same thing. They block H1 and they relieve the itching, the sneezing, and the rhinorrhea. Again, they do not have any kind of effect on congestion. That's where our decongestants come in. Okay. And as far as our side effects, they can cause a little bit of drowsiness, but typically they are labeled non-drowsy because they do not make you nearly as sleepy as the other, as diphenhydramine. They can still have some anti-cholinergic effects, but they are going to be nowhere near as severe as our first generations. Okay. So then some things to think about is that we need to monitor urine output for clients who have an enlarged prostate. Especially because of the can't pee. Okay? And then we want to make sure that we are not giving this to a client who has glaucoma or cataracts because of the can't see part, okay? Because it can increase the intraocular pressure, which is a part of glaucoma, and cause the vision to become worsened. All right? And that is it for our respiratory drugs. Oh, I forgot one. We have our nasal glucocorticoids. All right, so these are glucocorticoids, once again. So not many things have changed. They still decrease inflammation, but because we're spraying them into the nostril, it's going to decrease inflammation inside of the nasal passages. So it has less systemic effects as our inhaled or our oral glucocorticoids, but we can still get a sore throat, a headache, nosebleeds, and burning. All right. There we go. That is it for the respiratory medications. Y'all did great.